Shubha Madhyana. I welcome you all to the 7th session of Shalya Tantra, Tadvidya, Sambhasha, Parishat sessions, online sessions. Before we start today's class, I would like to start it with a small prayer. Om Jnananandamayam Devam Nirmalasphatiकाकृतिम् Adharam Sarva Vidyanam Hayagrivam Upasmahe. Om Shanti Shanti Shanti. Welcome back, all of you. So, in today's session, today is the 7th session of this online series on Bhagna. In today's session, we will be dealing with the further aspects of fracture. That is the fracture or the musculoskeletal injury with respect to the hip joint. Now, until previous sessions, we have dealt with various basics of the bone tissue, and in the last session, we saw the injuries or the musculoskeletal injury with respect to the shoulder joint. We saw what shoulder girdle was. We saw the basics with respect to the clavicle and the scapular fracture. We saw the very important, that is dislocation of the shoulder joint. So, in today's class, we will be moving on further. That is with respect to the musculoskeletal injury of the hip joint. So today we'll be dealing with injuries around the hip joint or of the hip joint. So now, what does this constitute of? So, to be called, it can be also called as it is the most difficult. If you have to categorize all those things, it is one of the most difficult injuries of the musculoskeletal system. So, it is one of the most difficult. Why it is most difficult, we will get to know in today's classes. Now, of the various injuries of the hip joint, what is that we get here is, so first is we have the dislocation of the hip joint. Next, we have that is fracture of neck of the femur, and the third is the intertrochanteric fracture. So these three forms the basis of the injuries around the hip joint, what we will be dealing today. So now moving to dislocation proper, we will just brush up the relevant anatomy for the hip joint. So what do we have? So first thing, we know that hip joint is a ball and socket joint. Now, while we have seen, the different factors that contribute to the stability or the integrity of the joint, one thing was the fashion or the design of the joint. So, in that, the best quoted example for a highly stable joint was the hip joint. So, we know now that because of this ball and socket design, it is a highly stable joint. So this is a very highly stable joint, that is the hip joint. Now the next thing what we have to see here is that, so we have what are the articular surfaces or the structures that participate in the articulation. We have the acetabulum and you have the head of femur that participate in this ball and socket joint. Now this acetabulum, this cavity, it is it is at an inclination of 30 degrees outwards and anteriorly. So this acetabulum is at an inclination of 30 degrees outwards and anteriorly. And here, with respect to the head of the femur and the long, this long shaft of the femur joint, this is, an approximation of 125 degrees is the angulation between the head of the femur and the shaft of the femur. So the angulation here between the head and the shaft is approximately 125 degrees to be seen. Now this is the basic, and next thing what we can see, what is important with very important with respect to the hip joint is its vascularity. Is the vascularity. Now suppose so we have the greater trochanter, and if it is like this, it comes like this actually. So here, what is the important vascular structures that we have to see here is, so the first one is here at this level, we have the medullary vessels. So that is the first one, and the next is, so it is almost, at the region of neck. So we have the medullary vessels at the region of neck. Then we have the retinacular vessels arising from the lateral side of the head. So here, we have the retinacular vessels from the lateral side of the head. So we can, this is the supply. Okay, so here it is this. Okay, and the next important, at the region of the topmost portion of the head, that is, we have the foveal vessels. We have the foveal vessels. So we have one, then we have retinacular, so this is RE, and the third one is foveal vessels. Now of these two, the medullary and the retinacular vessels are very important, because during any injuries of the hip joint, usually the disruption of these two happens, and because of which, the vascular supply is compromised. And when the vascular supply gets compromised, the next thing what the tissue ends up is with necrosis, that is avascular necrosis. Now, compared to other bony musculoskeletal injuries, avascular necrosis is very common complication that is associated with the injury of the hip joint, especially both the dislocation and the fracture neck of femur. So this is with respect to the blood vessels. So with this, we have pretty fairly, just brushed up the relevant anatomy that is needed for us to further move on with the injuries to the around the hip joint. Okay, without much of delay, we will start off with the dislocation of the hip joint. So the next point we'll be focusing is on the dislocation of the hip. Now, in this, there is classification, as we have seen in all types of injury. Even the dislocation of hip also has its own classification. So what are they? The first one is posterior dislocation. The next we have anterior dislocation, and the third one is the central fracture dislocation. So fracture dislocation was one of the type of classification when if you can go back through the session of where we dealt with the different classification of dislocation. One of the classification for traumatic dislocations were fracture dislocation. So here it is central fracture dislocation. Now, in the last class when we were dealing with the dislocation of the shoulder joint, we saw that with respect to the shoulder joint, anterior dislocation is very common than compared to the posterior dislocation. Here it is the opposite. Here usually in case of the hip joint, posterior dislocation is very common than compared to the anterior dislocation. With respect to both of this has a higher incidence. Now we will see what is the details of each of this. We will see the posterior dislocation in a little bit of detailedness, and the anterior and the central fracture dislocation. Little amount of knowledge is suffice, because the rest of the signs and symptoms and almost all the complications and stuffs remains the same. Only the pathoanatomy of them varies. So now first we start with posterior dislocation of the hip joint. Okay. Now, as we were seeing, we also discussed in the last class and in the first class, for every fracture, especially when we are dealing with fracture chapter, the mechanism of how a fracture happens, the mechanism of fall, or the event in which the fracture happens or a dislocation happens is very, very important. Now, in this case, how is the mechanism actually have to happen so that the head of the femur dislocates posteriorly? Now, before we put it up on the board as a pictorial representation, one thing we have to keep in mind is a posterior dislocation happens when the movement or the external force, it moves through the length or the axis of the femur when the hip is flexed. So that is important. Now, for example, we are if we can, I shall try to depict the pictorial representation in the lateral view. Now, suppose this is a chair and we have a person sitting. So this is his leg and this is the lower limb. So this is the thigh part of it. Okay, this is the trunk. So now for the fracture to happen in the posterior, the head of the femur to dislocate posteriorly. Now we know that suppose if we enlarge this part, so this is the thigh and you have the femur here. Okay. It's not an exact representation. This is just to try to understand the mechanism. Don't go into the exact anatomical details of this particular picture. So suppose we have the head, okay, and the acetabulum cavity. Now what happens? This is the leg and there is a force acting like this which moves. So this is our external force which is moving through the, this is the bone which is moving through the axis of the long axis of the bone. So what happens? This force pushes the bone such that the head is chipped off or it is pushed off of its cavity and it goes posteriorly. Now if I give an example, it becomes easy to understand. Now it is also called as a dashboard injury. Now why it is called as dashboard injury? Because now consider yourselves driving a car. So we are in the driving seat, we are sitting. So what happens? Suddenly a road traffic accident happens or something comes ahead of us. We go and hit it. What happens? So the tendency of the human body because of inertia is to move forward because the body is still in inertia. So in such cases what happens? Our knee, when in the sitting posture, our knee goes and hits the dashboard. So what happens? The same mechanism. From the dashboard, an external force is transmitted throughout the thigh, that is the long axis of the femur, because of which in this position our hips are flexed. So what happens? Now suppose if this is the position, this is our hip and this is our leg. Suppose consider. So suppose because of the dashboard hit from the dashboard, the force is moved along the long axis of the femur. So we have the consider to have the acetabulum cavity here and the head is fixed like this. So what happens? The head gets pushed and it gets forcefully pushed outside the acetabulum cavity. So this is the mechanism. This is very, very important. Posterior dislocation is very important. And with respect to every fracture, it is also important for us to know how the mechanism happens because of which the dislocation or fracture happens. So this is the mechanism of the posterior dislocation of the hip joint. I think that is made clear. And because of the commonness in road traffic accident, it is also called as the dashboard injury. So this is an extra added point with respect to this. Now the next one is diagnosis. Under diagnosis here, clinical features or the signs and symptoms forms the basic, basis of diagnosis of any musculoskeletal injury. So the first thing under diagnosis, what we get is the signs and symptoms. Now what we have at the signs and symptoms, so we have the classical DPS. D for deformity, P for pain, and S for swelling. So this is always there. Okay, so this is always there. Now along with that, especially here with respect to dislocation of hip joint or fracture of femur neck, okay, this deformity or the presentation is very, very important because that forms one of the basic clue for the diagnosis of the kind of fracture. So here what is the presentation? So here what happens? It is usually flexion, adduction and internal rotation. So suppose this is, consider this as the femur, this is the head of the femur. the head of the femur is posteriorly dislocated. So what do we have? We have flexion, we have internal rotation, and we have adduction. So this is the presentation that happens with respect to the lower limb. So that is important. So there is flexion. This internal rotation is important because you try to analyze and picturize the mechanism. So definitely then it is easy to remember this presentation. Okay, there is flexion, internal rotation, and there is adduction with respect to the posterior dislocation of the, that is dislocation of the hip. Okay, now the next thing what we have to do is, now obviously, so the first signs and symptom is DPS. Now the second one, suppose this is the particular length of your limb, and now whatever the head was supposed to be here, because of which the head is being posteriorly pushed away. So what happens? The length of the limb decreases. So it is a typical symptom in case of posterior dislocation of the hip, where there is shortening of the limb. Okay, there is shortening of the limb. So this is the next clinical feature we have to look for. Now the third one is that at cases you are able to feel the head of femur in the gluteal region. So this is the third clinical feature. And next is one thing, it is very important because usually the posterior dislocation of the hip, it is tend to be missed. That is because, especially in cases where there is fracture of neck of femur of the same side, or there is some other road traffic accident. In a road traffic accident, there is some other injury which is more grievous compared to this. Then in most of the cases, the posterior dislocation is thought to be missed usually. So in such cases, whenever there is a trauma that is affecting to the hip joint, surrounding region of hip or the pelvis, always it is better to confirm whatever it is with an X-ray. Only after that you have to rule out anything. Do not rule out only with the clinical features. We have to confirm with an X-ray before we rule out. So the X-ray of the pelvis in patients with fracture of the femur. So suppose maybe these are the signs what we are not seeing. Suppose a patient comes with to us with the signs and symptoms of fracture femur. Suppose there is a history of trauma, then we are not supposed to restrict ourselves with the end diagnosis of fracture of femur only, because in that cases the fracture femur will have more presenting complaints than that of the posterior dislocation. So in such cases, to avoid more the head is out of the acetabulum cavity for a longer time, higher chances for it to end up with avascular necrosis. So it also always have to be confirmed with an X-ray of the pelvis. So this is one important thing what we have to look for. Now as we were speaking of X-ray, now what are the radiological features that we are going to appreciate in case of posterior dislocation of the hip joint? So the first thing is, so now we go for radiological features. So the first is very obvious, it's a posterior dislocation. So the head is out of the acetabulum cavity, right? Now the second thing what happens is, now we know there is internal rotation. So what happens when the limb is internally rotated, with respect to the anatomy of the femur, the prominence of the the lesser trochanter, it becomes less than compared to that of the opposite limb. Why? The part wherever is the lesser trochanter is, it is internally rotated. So when you take an X-ray, it is less prominent than compared to the opposite side. So that is important. So you have the lesser trochanter, that is less prominent than the opposite limb. So this is the second one. Now what is the third one is that, now in the pathoanatomy, one of the very important things what we have to look for is, which I also forgot to mention, is that now this is the cavity and this is the head. Okay, so in the mechanism of this head moving out, there are all chances that if this is the cavity and this is the head, and the head is moving out. So there are all chances of, the head chipping out a portion of the posterior lip of the acetabulum, or it could even take a, like an avulsion fracture, what we had seen. It could also avulse a piece of periosteum from the surface, and it could take it along with that. So in the X-ray, it is very important for us to also look for additional, bony pieces. Additional bony pieces, if you are able to look for in the X-ray film, that is very, very important. So it is usually called as a chip fracture. So you have to look for bony chip if it is present. So these are the three main important things with respect to the radiological features what we can see in case of posterior dislocation of the hip. Now moving to the treatment aspect of it. Now, coming to the treatment aspect, the first thing what we have to do is reduction. And in case of, a dislocation of the hip joint, this reduction is an emergency. So this is very important for us to know. Why? Because whenever it is, dislocated, as long as the head of the femur is outside the cavity, so more is the chance or risk of avascular necrosis. So that is why it is very important to immediately reduce a dislocation of the hip joint. Now, what are the measures that you do to reduce? Now we know that reduction is an emergency. Now we will see how it is done, how it is reduced. So usually it is not done when the patient is in a wakeful state. It is done under sedation, usually not also even under sedation. It is usually done under GA. Okay. So under GA, the reduction procedure is taken. So usually it is a closed reduction. Usually it is a closed reduction. Only when closed reduction fails, so there are certain points where an open reduction is opted for. First is when a closed reduction fails. Second one is, when the patient is presenting to you very late. From the incident when it happened, when the fracture happened, from the point of incident to the, when he approaches the doctor, there is long gap. So in such cases, no chances are taken, and it is taken for an open reduction. And next thing, when open reduction is opted for, we saw that when it is associated with the chip fracture. So, or when suppose in cases of chip fracture, suppose this is the cavity and you want to reduce it manually. Suppose there is a piece of bone, the chip fracture, and the fragment is lying just here inside the articular surface. Then suppose even if you reduce back the head to the cavity, then definitely this piece of bone will start posing problems in the future days. So that is why even in these cases, this has to be removed and only then the head to be replaced. So in all these three cases, what happens? The closed reduction is manipulated to it is converted to an open reduction. So that is what we have to keep in mind. Now, how the open reductions are done, that we will see at the end, because it also accounts to the, one of the treatment aspects for fracture of neck. So that we will not deal now. We will just see how the manual reduction is done, and then we will move further to the complications in the next aspect of fracture femur neck. Now, how the closed reduction is done. Now, suppose this is the patient. Okay, so this is his trunk. So we have his leg here. So this is the knee joint. Suppose you consider. So what happens now? This is the pelvis part, or this is the hip part. Okay. Now, how the closed reduction is done is that the physician or the doctor flexes his hip so that his thigh and the leg are in right angles to each other. So that is this is the way the hip is flexed. Now what happens? We have two participants here. That is, we have two assistants. We need two people for this reduction. So the first person, what he does, so the first person here, he will catch hold, he will, put force at the level of pelvis so that the force is acting downwards, okay? He is thrusting at the level of the pelvis. Now, what the doctor does here is the second person is at this level, okay? What he does here, he will try to, he will flex the hip and the knee at the right angle and he exerts an axial pull. So at this level, the force acting at this level is upwards. So here the doctor exerts an axial pull. Okay. So what happens? Wherever here it is the femur head is displaced. So with the click sound, usually it is called as the sound of reduction. With that sound, what happens? The head will come back into the acetabulum. Now, how will you get to know that the head has in the acetabulum is there? You are able to elicit all the range of movements with respect to hip joint. Now, before that, that is not possible. But after that, you are able to move the move the hip joint in all the directions. So that is one of the signs. So after this, what they'll do is they'll apply as light amount of traction is applied and in a state of slight abduction, you go for rest up to 3 to 4 weeks. So this is how it is, close reduction is done. So after this 3 to 6 weeks fairly. So only after that you go for slow exercises and rehabilitation of the joint. So this is how it is done. So this is the manual wherein there is a downward force that is being thrust at the region of pelvic region and an upward axial pull by the doctor so that the head of the femur comes into place. Now, one important thing what we have to know with respect to this is, I request everybody to keep this in mind because the same beautiful manual is explained in Sushruta Samhita. When we move further to the Chikitsa Sthana aspect, we can get to know. Now, by then, if somebody is able to identify which is that manual which I am referring to, I'll be really, really happy and really, it is almost like, a delightful moment if somebody is able to identify that with, trying to apply whatever is the explanation here and whatever is the explanation given by Acharya, that whatever is the manual done by Acharya Sushruta is almost exactly the same as what is done for the dislocation of the hip joint. So that we will see when we deal with the Chikitsa Sthana aspect, Bhagna Chikitsa. Now we saw how close reduction is done. As I told, the operative part we will deal later. So this is the treatment aspect. And now moving towards the complications. Complications is very, very important with respect to musculoskeletal injury. So the first complication here, we have already dealt one. But before that, the main complication here is injury to sciatic nerve. Why? Because sciatic nerve just passes, behind the posterior wall of acetabulum. So it passes just behind the posterior wall of the acetabulum. So what happens when when the posterior dislocation of hip happens? So there are all chances that the head of the femur, it disrupts the posterior wall of the acetabulum, so that the sciatic nerve is, just behind the posterior wall, and that is also injured in the due course. So this is first one. Now the next complication is avascular necrosis. Why? As we saw that as long as the head is put, it is outside the cavity, it is devoid of vascular supply, especially the medullary vessels. So that is very important. So because of the compromised vascular supply, it ends up with AVN. Now, suppose you want to appreciate avascular necrosis for an, to appreciate in an X-ray, it almost takes like 1 to 2 years from the date of, incident. Okay, so it takes up to 1 to 2 years. So in an X-ray, usually, the area it appears as very dense. So that is with respect to avascular necrosis. So what is usually the complaint with respect to avascular necrosis is that the patient will always be complaining of pain. Okay, and this is one of the main complaints, symptoms in case of this. Usually it will be like for a period of painless period after for few months after the treatment. The patient will say he had symptomless or pain-free period, and after which there is continuous pain at the region. So this is one of the symptoms for AVN. So for it to appear on the radiological films, it takes up to 1 to 2 years. Now, one thing we missed here with respect to sciatic nerve injury was that, so if it is mild injury, then the usual complication is neurapraxia. So what is it? We also saw it in case of, shoulder joint dislocation, or wherein we saw that the axillary nerve is involved, where you can feel a patch of anesthesia or paresthesia at the deltoid muscle. So same thing happens here. Usually it reverts back to normalcy. If it is grievous injury, then it is very difficult to manage. Now after AVN, the third thing, what AVN could be a cause, because of AVN the joint could end up with OA arthritis. So it is important because everything is linked to each other. Now suppose there is OA, we saw that OA is one of the prime reasons for recurrent dislocation. So the patient could also end up with again dislocations of the same joint with trivial forces. So osteoarthritis is the next complication, and the last complication under this heading is myositis ossificans. So what myositis ossificans means is that, wherein suppose now this is the joint and you have a hematoma here. What happens in case of myositis ossificans is that this hematoma, it fuses around the joint and it will form a big mass, bony mass. So it will form a big bony mass at the joint, because of which you are unable to move, perform any complete activity of that particular joint. And very important, there is stiffness and there is pain. So this is one of the last important complication of the posterior dislocation of hip. So with this, we completed the posterior dislocation of hip. Now next, in just few lines, we will see what the anterior dislocation and what is the center fracture dislocation. So coming to the anterior dislocation, it is very, very rare. So the first thing is anterior dislocation is very rare. So here what happens is that in anterior dislocation, the leg is forcibly, it is abducted and externally rotated. So here it is. So if this is the bone that is coming anteriorly, so obviously your limb has to get abducted, right? That is, think this with respect to the, hip joint. So it is externally rotated. Okay, so it is abducted and externally rotated, the limb. Now the next thing what we have to know is, so here in posterior dislocation, it is limb shortening. Here there will be limb lengthening. Usually in all kinds of fractures and dislocations, shortening is the one. But anterior dislocation of the hip joint is one exception where there will be limb lengthening. So the other features are always the same. You have the deformity, swelling and everything. There we could palpate the head in the gluteal region. Here, the head of femur. So obviously it can be palpated in the groin area. So this much is suffice with respect to the anterior dislocation of the hip joint. The next one is center fracture dislocation. So in center fracture dislocation, what happens is that the femoral head, whatever is the head, the femoral head will be drawn towards medially, so that in certain cases, based on the extent of force, the head can completely lie in the pelvic cavity, in the pelvic region. So this is center fracture dislocation. How it does? It fractures through and it moves through the center acetabular area. So through that it pierces and it moves medially. So this is the medial way I want to show. So from this side, the head is moving medially. It is breaking through the center part of the acetabulum cavity, and the head is coming to lie almost in the pelvic region. So this is center fracture dislocation. Usually, whatever, even after high amount of good treatment, stiffness, pain will never decrease. Usually, it's a part and parcel of, and also the shortening, limb shortening. So this is usually associated with the center fracture dislocation. So with this, we completed the dislocation, anterior, posterior and center fracture dislocation of the hip joint. The next important is the fracture neck of femur, after which we will wind today's session. Okay, now So now we are dealing with fracture femur. Okay. Now, what are the important things again here is, so first of all, fracture at the neck of femur, it is classified as intracapsular and extracapsular. Now, why it is called so? Now, suppose this is the head. You have the greater trochanter. You have the lesser trochanter. 1 minute. Something like this. Okay. Okay. Now what happens is, okay. Now what is intracapsular and extracapsular? Now this is the articular capsule that runs through, that covers, okay, and okay, now it is more clear. So now we have it at the capsular end. Now, usually the fractured neck of femur, it is called as intracapsular and extracapsular. What is intracapsular is, suppose the fracture happens within the capsule. So now we have the capsule here. Suppose it happens here, then it is called as intracapsular. So suppose the fracture is here and we have this is our articular capsule. So this is called as intracapsular. Now what is extracapsular is, if suppose it happens between the trochanters and which is outside the capsule, then it is called as extracapsular. But when we are referring to the fracture neck of femur, always it refers to the intracapsular. So if you are saying that it is a fracture neck of femur, then remember always it goes for intracapsular fracture. Okay, this is extracapsular when you are referring to, it is called as intertrochanteric fracture. So the second one is called as intertrochanteric fracture because it runs between the two trochanters, that is the greater and the lesser trochanter. So this is very important. So we have intracapsular and extracapsular as one classification. Intracapsular always is, when we are talking as neck of femur, then it means it is an intracapsular fracture. When it is otherwise called so, it is called the outer extracapsular is called as an intertrochanteric fracture. Now this is the basic thing what we have to know. Now moving to the further pathoanatomy. So here, one thing what we have to know is, most of the fracture of femur here, they are displaced. Now why, we will see further. Okay, so the first thing we have to know is, it is a displaced fracture. So what happens here, it is that it is externally rotated, adducted and proximally migrated. So that is important. It is externally rotated, adducted and proximally migrated. We will try to understand this now. Now suppose okay, so this is the greater trochanter and you have the fractured, the head is here somewhere. Okay, so what happens is, just the distal part, we know that always displacement occurs with respect to the distal part. So what happens to the distal end of the fragment is that it is usually externally rotated. Okay, when it is externally rotated, it is because of the nature of the anatomy, it is towards the body, it gets adducted and this part is usually pulled medially. So that is what is called as proximally migrated. So this is what is the pathoanatomy of the that is the fracture, that is fracture neck of the femur. Now the next thing is that with respect to this fashion, this pathoanatomy with respect to intercapsular and the intracapsular and the extracapsular. Okay. Now, suppose the fracture is intracapsular, then all these displacement are, you know, a little bit lesser. All of these are a little bit lesser. Now, suppose why? Because you have a capsule that is somewhere holding on to the proximal, the distal fragment, that it is not letting the distal fragment to displace or, you know, get distorted even more. Now, all these things is exaggerated. All these are exaggerated. Suppose it is an extracapsular fracture, because, you know, the distal end is much more free. It is not held or it is not restricted by any attachments. So, the displacement of the distal fragment is even more. So, this is the basic pathoanatomy what we have to look for. Now, the next important thing is classification of fractures. Okay. Now, this is pretty easy to remember also. So, the first one is, it is the anatomical classification. Okay. So, the first one is an anatomical classification. So, here what happens? So, this is the head. You have something like this. So, this is the neck part. Okay. So, from here we have the, suppose it is like this. So, there are 3 zones. So, one is this, this and this. Now, what it is named as, so the first one is subcapital, transcervical, and this is basilar. Okay, or basal. So what it means that, suppose now the fracture is just, you know, it is very proximal or just at the region where this rounded contour ends. So this is called as subcapital variety. The next is, if it is running, you know, in this portion of the neck, it is called as transcervical. The next one is at the lowermost portion of the neck, it is called as basilar, or it is also called as the basal variety. Now, with respect to anatomy, one thing we have to know is, more proximal the fracture is, more proximal it is, then it is, less good is the prognosis. The prognosis is bad. So this is, we have to, this one thing we have to keep in mind. More proximal, then the prognosis is much lesser. So this is one variety, that is the anatomical variety. You have the subcapital, transcervical and the basal. It is simple when we put it in terms of a figure to remember. Now, next, capit is head. So suppose if it is head, just below is sub, so capital, transcervical, that which is moving to the cervical part. The last one is at the base, so that is why it is called as basal. Now, certain questions can arise, but this is, it is not that all the fractures of the neck, it happens only in these 3 varieties. We could also end up in a fracture which is moving, you know, starting in an oblique fashion, starting from the capit region, and that is ending at the base. So all those possibilities are also possible, but to put things under, you know, a common heading, these 3 classifications are usually done. Okay. Now, the next classification is called as Powell's classification. Now, what does Powell's classification say is that it is with respect to the angle. Now, suppose this is, okay. So, you know, the angulations here are different. So, this is like this. This is like this. And this is like this. So, what does Powell's classification say is that the more the angle, the more unstable is the fracture, and it is more, worse is the prognosis. So, it says that more is the angulation, worse is the prognosis. So, this is very important for us to know. Why? How a classification has a hint for the prognosis of the fracture. So, we saw the anatomical classification, and next is the Powell's classification. There are many classifications also. There is also called as Gardner's classification, which is according to various. It is a stage-wise classification. But at this level, I think these two classifications are suffice for us to be going through in this particular topic. Now, moving on to the next is the mechanism. So we saw the mechanism in case of dislocation of the fracture, right? Here also we have to look for the mechanism. So usually it happens. So usually in elderly, it is because of a fall. Okay. So trivial force could render the femur break. So in case of younger people, more moderate forces necessary for it to happen. The next thing what is important here is that with respect to the diagnosis. With respect to the mechanism, one thing I forgot to mention with anterior dislocation of the hip is that now for the posterior dislocation, the mechanism we saw, just deviate yourselves from here so that I can tend to forget it to explain it later. So I finish it off right now. So in the posterior dislocation, we saw that the force has to move through the entire axial root of the femur so that the head gets displaced posteriorly. Now, in cases of anterior dislocation, one important thing is when you fall from a greater height and when the limb is in a position of getting abducted more. Now, like in cases, you're walking through where there are grills, supposedly your foot gets stuck inside it, and without your knowledge, you tend to move. Suppose if this, hip joint region, the hip joint is subjected to a large amount of abduction, then also it could end up with anterior dislocation. So falling from a tree or a great height, all those are mechanisms for anterior dislocation of hip joint. Now moving back to the mechanism of, this is fracture femur neck, don't get confused. This is the mechanism of fracture femur leg. So here it is, fall is the main reason. No particular mechanism has to have, is looked upon in case of the fracture of femur neck. Now moving on to the diagnosis. Under the diagnosis, the first thing what we have to look for is the clinical feature. So here what happens is, usually in cases of fracture femur neck, the patient arrives to you. The first thing is pain in groin. So very surprisingly, sometimes the patient may even walk to you. So until and unless when you palpate, you look for a tenderness at the groin region. So the pain, suppose it is very young adult. So in certain cases, if it is not much displaced and it is a trivial thing, your patient are even able to walk with certain amount of pain. And when the tenderness is more at the region of groin. Now, suppose in elderly, what they complain? In elderly, they complain of issues like they are not able to walk, or they are not able to lift their legs, and when you touch it is painful. So an SLR, straight leg raising, is also it is not possible. A direct SLR is not possible to elicit in patients with fracture dislocation. DPS is again there, that is common for all, that is deformity, pain and swelling. Along with that, where exactly the patient presents with pain is very important. Here it is in case of the groin region. Now the next thing is that the leg is usually external rotation. We saw what is the position or what is the deformity. So when you examine, the leg is externally rotated. Okay, now but if the leg is externally rotated, what we see is that if this is the leg, and it is externally located, suppose my patella is here, then when the legs get externally rotated, the patella is seeing outwards, right? It is facing laterally. So when you see, compared to the other leg, patella is facing more laterally. So this is important. Okay. Another important thing what we could see is here also there is association of shortening of the limb. Why? Because we saw in case of displacement, there is proximal migration of the distal end of the joint. So because a distal end of the bone. So that is why there will be shortening of the limb. The next thing is there is tenderness in the groin, and so this is there. Any hip joint you want to do, you are unable to do the movement of the hip joint movements, or you are not able to do, and active SLR, straight leg raising test is negative. That is, you are not able to, not negative, you are not unable to elicit that particular test. So these are the things what we have to look for. This comes under the clinical features. Now, next important thing, what are the radiological signs we see? We'll brush through very quickly. So the first one is, obviously there is a break in the medial cortex of the neck. So you can see a break in the cortex of the neck. So that is one thing. Then definitely, because there is external rotation, that is very evident in the X-ray also. External rotation of femur is very, very evident. So this is the next important thing. And the lesser trochanter is appearing more prominent. So in the first case where there was internal rotation, what we saw in the radiological thing was that the lesser trochanter was less prominent compared to the opposite limb in case of posterior dislocation. Here it is opposite. Why? Because you have an external rotation that is happening, not an internal rotation. So obviously what happens? The lesser trochanter, which is on the medial side, is becoming more prominent. So you have a lesser trochanter that is more prominent. So these are the radiological signs which you will be seeing for. Now next, moving on to the treatment aspect. Moving on to the treatment aspect of it. Usually it is very important that this is usually termed as an unsolved fracture. So the name given to the fracture neck of femur with respect to the treatment is that it is called as an unsolved fracture. Now, why it is called as an unsolved fracture? Because there is always high incidence of complications irrespective of treatment. Okay, so that is why it is called as an highly unsolved fracture. Okay, now moving on to the treatment aspect of it is that usually here, a closed reduction is very difficult because as we saw, the proximal end is very, very short. Supposedly, if the proximal and the distal end, both of them were of an approximate same length, then it would be easier for the bone to stand in position. But on the contrary, what happens here, suppose it is a subcapital, fracture, so the proximal end is very, very tiny than compared to the entire length of the distal end. So in such cases, it is very difficult for you to, reduce it and to bring it to an alignment to so that it is immobilized in the same anatomical position for a longer time. So that is one of the major complications or, major drawbacks for why a closed reduction usually is not opted for in cases of neck or fracture neck of femur. Another thing is that it is highly, it is a highly unstable fracture. It is a fracture that is tend to move to displacement. Because, suppose if it is intracapsular, certain amount of, stability is there. But suppose it is not so, then the distal fragment always usually gets displaced. So, even if you reduce the fracture, and it is very difficult to immobilize the limb in the same anatomical, approximation. So that is why closed reduction is usually not opted for. So what do they do in active, open reduction is, so the first main motto is to achieve union. So it is very, very important because this is what is usually compromised in cases of fracture neck of femur. So to achieve this union, what they go for is internal fixation. Okay, so that is why they opt for internal fixation between the two fractured ends of the femur. So usually in elders, what they do is that, so usually it is called as ORIF. So what does ORIF means? It means open reduction, internal fixation. So this is one classical example where it is done. So in open reduction, what you do? Open reduction is where you're opening up the part and you're reducing the bony parts into its normal anatomy, and then you're fixing it internally so that it lies in the same anatomical approximation. So for this in elderly, what they do is they use artificial prosthesis. Okay, so in the place of the bone, they use artificial prosthesis in the place of the head, and then they use screws to fix up the fractured end. So for fixing, for internal fixation, there are many things used. So one is that there are many things actually. One example is DHS. It is called as dynamic hip screws. Okay, so this is one. Another one is you have cancellous screws. So there are many actually. So this is one important among the materials that is used for internal fixation. So this is with respect to the treatment aspect of fractured neck. One important thing we left out is the complication. So with respect to complication, what do we have? I told you the main aim of whatever the reduction, internal or external, is to achieve union. So if that is given more importance, then that obviously tells that one of the main complication of fracture neck of femur is non-union. So that is why achieving a union is the prime goal for the treatment for fracture neck of femur. So this is non-union. Okay, non-union because of various reasons. I told you because of inadequate immobilization is one. You are not able to. This is very important. Okay, inadequate immobilization is one of the main reasons for non-union, and usually 30 to 40% of fracture neck of femur goes into non-union. Okay, the next common, again, it is what we saw earlier. AVN, we have osteoarthritis. So AVN, many a times, again, when there is the disruption at the neck level, so medullary vessels are disrupted. So because of this, the vascular supply is compromised, as a result of which we have the vascular necrosis, right? And many a times, this itself becomes a reason for non-union also in later stages, or not in later stages, in that particular stage, because of the the decreased nutrient supply, the union is also disrupted. Next is OA. AVN itself becomes the reason for OA many a times, and yes, these three are the main three complications for the fracture neck of femur. So with respect to the treatment aspect, I said for the open reduction and internal fixation, which applies even to that of the dislocation of the hip joint. Now, important thing is there are three aspects that you could do. One is osteotomy, the other one is hemiarthroplasty, next is excision arthroplasty, hemiarthroplasty, and the next one is a completely, a total full arthroplasty. So these are the three types. Okay, so in excision, I'll just tell it in one sentence and end it here. So in excision arthroplasty, what happens is, now suppose this is the joint, it is totally disturbed because of AVN or something like that. What do they do is, they excise that particular part, okay, and this is the cartilage. Now this is the articular surface. What happens when they leave this here, the fibrous tissue develops between this cavity, and later you can use the joint for its motility. So this is excision arthroplasty. Now in hemi-excision arthroplasty, what they do is, now there are two articular surfaces. One is with respect to, okay, here you have the femur head, okay, the greater trochanter and the body here. So in excision arthroplasty, what they do is that only one particular articular surface that will be replaced, and it will be replaced with a prosthesis. So suppose the hip joint has ended up with avascular necrosis. So what they do, they excise this part. Okay, this is one articular surface, and they replace it with, so this is the prosthesis. Something like this, we could have, you could have had seen that there are made out of materials where it looks like a steel, material thing, where it is a solid thing which will definitely, it will have the same shape as that of the head of the femur, and it will have a projection that will be put protruded within the medulla or within the central cavity. So this is called as hemi-excision arthroplasty, where only one articular surface is replaced with an artificial one. Complete excision arthroplasty, such cases, in certain times what happens, even the joint, articular capsule and the both the ends, even this articular surface and even this articular surface, both of them are replaced with artificial synthetic ones, which are called as prosthesis. So this is, this is the treatment for even what I said, we'll deal it later with respect to the posterior dislocation. So whenever there is, the proximal end of the femur has to be replaced, or it is not functional because of AVN or something like that, then this is how, they are replaced, so that still the joint integrity or the stability or the movement can be maintained. So this is with respect to it. So with that, today I think we almost, I think we've fully completed the modern part of it with respect to the fractures and dislocations. Now, two important things we are left behind. Now, it is taking a end the sessions on Bhagna, because it is quite important, and it is that particular topic which is usually not dealt completely in anywhere. Usually it is left behind only with by hearting the types of Kanda Bhagna and knowing the classification of fractures. So usually the class ends there. But since all of these are very important, I am taking a little longer session on Bhagna, so that it incorporates all the detailed aspects of it. So maybe another 1 to 2 sessions is needed for us to complete the session on Bhagna. After that, we'll move on further topics. So we are left with, the Bhagna Chikitsa aspect from the Sushrita Samhita. And we are dealt with very important, that is osteomyelitis. So with this, I'll try to incorporate both of them in one class. If not, we will extend it up to 2 class and then move on further. So I think with this, we have completed pretty well on the injuries to the hip joint. And I would like to end today's class again with a small prayer. Om Gnananandamayan Devam Nirmalasphadikakritim Adharam Sarva Vidyanam Hayagrivam Upasmahe. Om Shanti Shanti Shanti. Have a good day. Take care.